All right, let's dive into a really critical topic for your anesthesia exams, monitoring neuromuscular blockade. We're going to break down everything you need to know to feel confident about this.
So, I want to start with a number that honestly is pretty startling. It comes from a study by Devine and his colleagues.
So, what is that 45%? Well, believe it or not, that's the estimated percentage of patients who, after getting standard intermediate-acting muscle relaxants, were still showing signs of paralysis when they got to the recovery room. Almost half. Yeah, this hidden danger has a name: post-operative residual curarization, or PORC, and it's a huge patient safety issue. So let's break down exactly how we can see this invisible risk and, more importantly, how we can prevent it. Okay, so here's our game plan. We'll start with the why, understanding these unseen risks. Then we'll get into the how, the basic principles, the different patterns we use to test the nerves, and how we actually measure the response. And finally, we'll pull it all together and talk about how this works in real-world clinical practice. Right, first things first, why does this all matter so much? Well, the thing you absolutely have to understand is that even a tiny bit of leftover muscle weakness, it can be incredibly dangerous for the patient. And the dangers are, well, they're really serious. We're talking about everything from just feeling weak to life-threatening lung problems. I mean, think about it. If your throat muscles are weak, you're at a higher risk of aspiration. If your body can't respond properly to low oxygen levels, you can't protect yourself. This is exactly why monitoring isn't just a nice-to-have, it's absolutely essential.
So, how do we stop this from happening? Well, the whole principle of monitoring is actually pretty straightforward. We use a small electrical current to stimulate a nerve, and then we measure how the muscle attached to that nerve contracts in response. Now, to make sure we're getting a really solid, reliable reading, we need to activate every single nerve fiber. To do that, we use what's called a supramaximal stimulus. We basically find the current needed for a maximal contraction and then dial it up another 25%, just to be sure. This makes our measurement consistent and repeatable every single time. And the gear we use, the nerve stimulator itself, has some really specific features to make sure it's accurate. One of the most important things is that it delivers a constant current. Now, why does that matter? Well, skin resistance can change. A constant current device automatically adjusts its voltage to push through that resistance, which means the nerve gets the exact same stimulus every single time we press the button. Okay, so let's get into the different patterns of stimulation. You can think of these as the language we use to communicate with the nerve and figure out just how much muscle relaxation is on board. Okay, the number one, the absolute workhorse you're going to see all the time in clinical practice is the train of four, or TOF. So what makes it so useful? The most crucial part is that you don't need a baseline measurement from before the drug was given. You can interpret the results right then and there. Now, this is where we get to the really key concept, which is fade. When a patient has a non-depolarizing block, each of those four twitches gets weaker and weaker. The fourth twitch is weaker than the third, which is weaker than the second, and so on. This fade is the critical sign we're looking for. So how do we actually put a number on this fade? We use something called the TO-fresh ratio. It's super simple. It's just the height or strength of that fourth twitch divided by the strength of the first one. And that simple number is our single best indicator of how well the patient is recovering. Okay, if you're taking notes for your exam, highlight this next part. This is so important because it shows how much our standards for patient safety have evolved. For years, we thought a TOF ratio of 0.7 was good enough, but we now know that at that level, patients still have significant weakness. The evidence is overwhelming now. To be safe, we have to see a TOF ratio of greater than 0.9 before we can be confident that the patient can protect their own airway. So TOF is our day-to-day tool, but we have other patterns in our toolkit for specific situations. Take the post-tetanic count, or PTC. You'd use this when you have a really deep block, so deep that you get no response at all from a train of four. It's essential for those surgeries where you need profound relaxation because it helps us predict when we can expect to see the very first twitch of the TOF come back. All right, so we've got our stimulus patterns down, but how do we actually measure the muscle's response? This is where we see a huge critical shift away from just feeling the twitch to using objective, quantitative methods. You know, for a long time, people just relied on sight or touch, but that is a trap. It's just so unreliable. There was this landmark study by V.B. Mogensen, and its finding was a bombshell. It showed that even highly experienced clinicians can't feel or see any fade until the TOF ratio drops below 0.4. Just let that sink in.
the patient is still significantly paralyzed, and we can't even detect it with our own hands. This is precisely why we need a better way. And that is why we need quantitative monitors, machines that actually give us a number. So let's look at the main types. You've got mechanomyography, or MMG, which is the super precise gold standard for research, but it's just too clunky for a busy operating room. Then there's electromyography, EMG, which measures the muscle's electrical activity. It's less bulky, but can be susceptible to electrical interference. Which brings us to acceleromeography, or AMG. This is the one you'll see pretty much everywhere. It uses a tiny sensor to measure the thumb's acceleration. It really hits that sweet spot of being easy to use while providing the objective data we need, making it the de facto standard in clinical care. All right, so let's bring all this theory back to the bedside. Putting this into practice means we have to decide where to monitor. And believe me, the choice of which muscle to monitor is definitely not random. The key, and this is so important, is using the right muscle at the right time. At the start, for intubation, we're going to monitor a central muscle, like the one around the eye. Why? Because it gets paralyzed quickly, and it's a great indicator for the conditions at the vocal cords and diaphragm. But for recovery, and this is the clever part, we switch to a peripheral muscle, like the adductor pollicis in the thumb. It's one of the last muscles to get its strength back. So if the thumb has fully recovered, we can be really confident that our core muscles, like the diaphragm, have also recovered, giving us a great margin of safety.
Okay, let's nail down the absolute must-know takeaways for your exam. If you remember nothing else, remember these points. 1. Pork is common and it is dangerous. 2. 0.9. That is the magic number, your target TOF ratio for safe recovery. 3. You must use a quantitative monitor. Your fingers are not good enough. 4. Different muscles recover at different rates, so monitor the right one at the right time. And finally, a huge safety point. Only try to reverse the block when you can actually see at least 3 or even better, 4 twitches on your monitor.
Just so you know, the information in this explainer was built on some really key papers, including a 2006 article by McGrath and Hunter, and a more recent 2023 review by Verghese, Raju, and Chapman. And that really leaves us with a final, and I think crucial question for our practice. The science is settled. We know the risks are real, and we know the solution works. The big challenge now is implementation. So how do we, as a profession, make sure that quantitative monitoring becomes the non-negotiable standard of care for every single patient, every single time?